before we finish the nervous system, you will have, let's see where we were first. We were right here. Okay, so you guys will have a take-home quiz over nervous system during spring break. It's going to be long, but it's take-home, it's open book. You should be able to find all of the answers. Please make sure that when I post the due date, you pay attention to it. Because I don't think the app tells you when it's due, does it?
It does. It gives you how many days are left.
How many days are left, but it doesn't tell you the time, does it? Okay. So pay attention when I post.
The last 24 hours, though, it does say 15 hours left, 12 hours left.
Does it send you like a notification or something?
No, but when you click back into Top Hat, it
Okay. All right. So I don't know what the student side looks like from Top Hat. So make it your responsibility to make sure that you get it done once I tell you the date. I haven't decided the date yet, though. It'll probably be the Monday before you come to class, right? So that you'll have studied it, right? And so if you want to go, just get schnockered and do whatever the hell you want during spring break, you know you should be done by Monday, right? You should be like, I got to get it all back together and put the parts back in the right place and hydrate myself and eat some real food. That's how it was in Texas anyway. People don't spring break here like they did there. There was just like freaking bacchanalia. Okay, so what we were doing is we were going through the plexuses, yeah? We were going through the spinal nerves and the plexuses, and here's where we were. We did, what's this plexus? Yeah. Oh, sorry. Imagine. Okay. Okay. What is this plexus? Cervical. And this one? Brachial, yeah. C5 through T1 is brachial. And then we get into these thoracic spinal nerves. Remind me how you refer to spinal nerves in short form. What the thoracic spinal nerves would be what? T1 through T12, right? Okay, that makes sense? Okay. The long name for them, just so you know and don't get confused, is thoracic spinal nerves, cervical spinal nerves, for instance, right? Okay, so we're in the thoracic spinal nerves, and the thoracic spinal nerves do not form a plexus. You can see what they do right here. Do you see? What they do is instead of forming a little wad or net of nerves, what they do is after they come out, they all run relatively parallel to one another between the ribs, and they form the intercostal nerves. Intercostal nerves, does that make sense? So these guys are going to form the intercostal nerves, and you can see them here as well. The intercostal nerves just go between the ribs. And so what muscles do you think they innervate? Yeah, they innervate the intercostal muscles. They also have a little bit of sensory function. So the sensory function from the anterior and lateral chest wall and a little bit from the pleural cavity. So like when you're feeling this sensory, that's intercostal nerves, right? I don't know what it feels like when you feel something inside your pleural cavity. I suppose I would know if I had pleurisy, but I don't. So I can't imagine what that feels like quite yet. Okay, so, and then we're going to move on to the next plexus. You ready? Okay, so let's figure out how we would identify it. The lumbar plexus is basically L1 through L5, although L5 is also in the sacral plexus, so it has fibers going into each one. Do you see it? And remember that you guys said that you could recognize the lumbar plexus by process of elimination because it doesn't have any of the landmarks of the other plexuses. Yeah? Does that make sense? Okay. So L1 through L5 is where it comes out. So this is actually a pretty easy plexus at the level that you guys need to know it. Because the lumbar plexus is primarily innervating almost exclusively the thigh. Okay, so if you find it in a cadaver, let me show you where you would find it. So if you find it in a cadaver and you're dissected, what muscle is that? Yeah, that's what it is. Okay, so you can see that most of it comes out right over or right next to the psoas major. Do you see that? Okay, so, and then you really only need to know two nerves out of it, and they're really easy because there's only two of them. One of them is a little bit more lateral. It will go through the inguinal canal, and you'll find it on the anterior thigh, and it's going to be the femoral nerve. And the other one's more medial, right here, and it goes through the obturator foramen, and it's the what nerve? Obturator nerve, right? Like, and you only need to know two, so it's not that freaking hard. So look here. Now, these two, before we get into the specific details, look, the femoral nerve comes through here. Do you see it? And then it has boatloads of branches. And of course, they all have names, but you don't need to know the names. So any nerve that you see going to the anterior thigh, it's the femoral nerve, right? And then this one, do you see where it goes? Through the obturator foramen to the inner surface, the medial thigh, right? That's the obturator nerve. So you're not going to be surprised at what they do. You ready? Okay, so let's look at the femoral nerve. If you look at what the femoral nerve, what it does is almost all of the muscles of the anterior thigh. Not all of them, but almost all of the muscles of the anterior thigh. So let's make that make sense again. If it's doing almost all of the muscles of the anterior thigh, then tell me what actions are probably associated with that nerve. Extension at the knee, flexion at the hip. Now, not all of them do both actions. We're just putting that together generally. With me? So we're trying to make sure that we can use our body kinesthetically to help us remember. So when we think femoral nerve, we hand here, right? Okay. And then luckily, the sensory activity of the femoral nerve corresponds mostly, only it goes a little further. So you're going to have to list those muscles if you haven't. It's 8 different anterior thigh muscles. You can see them here. How many of you guys have already done this? Okay, good. A few of you. You're going to have to do it for a lab anyway. It's not hard to find. And if you take this picture and look at it while you're actually listing them, it actually makes sense. You can see all the muscles that it's doing. So those muscles. And then what does it do as far as sensation? Here's what the femoral nerve does as far as sensation. What it does is basically almost the entire anterior thigh, yeah, all the way down to the medial surface of the foot. Right? So this is the action that it does, yeah? And once you get your leg up, it does all of this sensation. What nerve is that? That's the femoral nerve, right? Okay. So you may look like an idiot when you are doing that with your body, but nobody can take that study tool away from you, and nobody can take the visceral memory of actually doing those actions away from you either, which is really nice. One of my students a couple of semesters ago told me that it was not very elegant the way that I teach muscles. And I was like, I don't give a nobody has ever told me I was elegant under any circumstances. So I gave up a long time ago. And I was like, what the hell? Why did you have that expectation of me? Okay, so obturator nerve. The obturator nerve does what you think it would do. It's pretty damn easy, right? It is going to, I mean, you saw where it was going, right? Here's where it's going. It's going through the obturator foramen, and it's going to the medial surface of the thigh. And so guess what it innervates? All of the adductors plus the gracilis. Yeah? And that makes total sense. Just look at where it's going, okay? So tell me the activity that it is going to be responsible for doing primarily. Adduction of the thigh, and then it's going to, I hate this picture because it looks like that's the outside of his butt.
But it's inside.
But it's inside, right? Okay. So it is actually going to be responsible for sensory innervation right here. So in order to remember, it does this. Whoop, catch your hand. This will get you slapped if it is not you, right? Okay. If it is unwelcome. So if somebody creeps on up there, they're going to get slapped for stimulating your what? Obturator nerve. Exactly. Does that make sense? Okay. They should have done something to show that it was a mid-sagittal section right there, because that's totally counterintuitive. I mean, you get down here and you can tell that it's the medial surface of his foot, but that's confusing because that's a booty right there. Okay. That's the anatomical term for it, by the way. Okay. Ready? Okay. So 5 medial thigh muscles, pretty damn easy. Yeah? And then sensory function is proximal medial thigh. Now let's go into the sacral plexus. So I think, by the way, that with the level that you guys are learning at, the lumbar plexus is the easiest, right? Maybe the second easiest. I mean, cervical plexus, you only have to know one nerve out of it. So the lumbar plexus is really easy too, though. Okay, so when you get into the sacral plexus, which is right here, let's show you what it looks like from a couple of different ways. So please note that when you start the sacral plexus, basically it's going to start about L5. Sometimes it has some fibers from L4 too. And it goes all the way down to S. Most of them come out of S4, very few out of S5, but it's all the way here. But look, notice that it goes posterior to the os coxae instead of anterior to the os coxae. So when you are looking for the sacral plexus, you are usually looking at a prone cadaver, right? And when you're looking for the lumbar plexus, you're usually looking at a supine cadaver. Does that make sense? Okay. So now it starts out, you can see in this figure right here that it starts out, where are we? It starts out anterior, but then it dives back, right? Does that make sense? Everybody see it? So this is a posterior view. So it went forward. So it started out on the front side, yes, and then it dived backward, right? So the nerves actually come out the anterior surface of the sacrum and then go down the posterior surface of the thigh. Is that okay? Okay. So this is a little bit of a hard dissection to do, so you don't usually see it from this view, although there is one cadaver on Jordan campus that has this view dissected. You usually see it from this view. You usually start following it that way, okay? So this has a few nerves. These two, the top two are kind of hard to find. I'll show you where they are, and then I'll tell you where to look for them in the cadaver. Okay, the superior and inferior gluteal nerves. So do you see them right here? They're coming off really, really soon after it goes to the backside, the superior and inferior gluteal nerves. So the way that you are going to find them is you are going to have to find a cadaver that the gluteus maximus and the medius have been sliced so that you can reflect them. Does that make sense to you? Note to self, though. They are really easy to pop, those nerves. So you need to be really gentle when you're pulling them back. It's kind of like, remember the pectoralis nerves, the pectoral nerves, the lateral and medial? How did you find those? You flip back the pectoralis major, and they're between the major and the minor. With these, you need to flip them back. So look at the difference for me. The superior gluteal nerve is superior. It's also bigger. Yeah, and the inferior nerve is inferior, it's also smaller. So does it surprise you that the superior gluteal nerve is actually going to innervate more than the inferior gluteal nerve? Does anybody know what the superior gluteal nerve innervates?
Maximus and minimus.
Maximus and minimus, and what about the inferior? Do you have it written down? Just the maximus. Does it make sense to you that the maximus actually has double innervation? It's a pretty big muscle. Okay? Does that make sense? Okay, so now neither of these two nerves have sensory function. Okay, so they're just motor function. Everybody go with that? Okay, so then we get to the biggest nerve in the body. Do you see this big honker right here? This is the sciatic nerve. Okay, and the sciatic nerve is called that because it heads through where? Any idea?
Sciatic notch.
Yeah, exactly. It goes through the greater sciatic notch. Have you guys ever heard of sciatica? Okay, so how do people get sciatica? Any idea?
Compression.
Yeah, the compression, especially unilateral compression, historically speaking, and still to this day, males are more likely to get it because they carry wallets in their back pocket, and usually just one, right? And sometimes your wallet can have have you ever seen your grandpa's wallet? It's like that. Right? You're like, I have to have everything. And now you have 72 cards from every place. So if you always carry it in the same side, it tends to depress one sciatic nerve, and you'll start to get tingling or pain down your leg, because the sciatic nerve is going to do everything in the leg pretty much. There's a couple of exceptions that that didn't come from the lumbar plexus, right? So I just did the glutes. But remember that really the lumbar plexus primarily just did anterior and medial thigh. Now we have to do the back of the thigh and the entire leg all the way down to the foot. And most of that will ultimately branch off of my sciatic nerve. Biggest nerve in the body. If you can't find the sciatic nerve, I don't even know if you should pass that lab, right? It's ginormous, okay? So the sciatic nerve, so the thing about the sciatic nerve is it's the largest nerve in the body, but None of the muscles that you learn are directly innervated by the sciatic nerve. They're innervated by branches of the sciatic nerve, branches that come off of it. Does that make sense to you? So it's not that it doesn't innervate anything. It doesn't innervate anything that you're responsible for. So after it branches or after it gets past a certain point, so let's follow it. So it's the sciatic nerve here, but it's not showing you that actually after it goes past a certain point, here is the sciatic nerve, and then it becomes the tibial division of the sciatic nerve or the tibial nerve. So it becomes a different nerve almost immediately, and that's what you say innervates things. Okay, so let's look at what that one is going to do. So the tibial nerve is a continuation of the sciatic nerve as it goes into the thigh and all the way down to the leg. Does that make sense? Okay, and it's going to go down anterior, posterior surface. Posterior surface. Okay, so let's follow it. You ready? Okay, so all of this is considered tibial nerve after it's going down this direction. And so the tibial nerve is busy. It's going to be doing a hell of a lot of stuff. It's going to innervate 4 posterior thigh muscles, 5 posterior leg muscles. Okay, and you can write them down later, and you certainly should. Okay, but you can also see most of them here. So tell me as we're going through this. Okay, if you innervate posterior thigh muscles and posterior leg muscles, what kind of actions are associated with the tibial nerve? Posterior thigh muscles are what? Extension at the knee, and maybe a little bit of extension back here too. But flexion at the knee, and then what is it going to do down here? Plantar flexion. Yeah. So stand on your toes and pull up, right? That's what it's going to do. So all of those muscles, I think it is the other hard one. There's one hard nerve in the brachial plexus that innervates 11 different muscles. Do you remember which one that was? The radial nerve. That one's hard. And then this one is the hard one in the sacral plexus. Almost all of the rest of the nerves are pretty easy. They just do a few things. This one does a boatload of stuff. So, and then what does this one do as far as sensory innervation? The sensory innervation that it does is all the way down at tickle your foot, right? So the bottom of the foot, almost the entire bottom of the foot, is actually innervated with the tibial nerve. So this tibial nerve, so heel, if you step on something, that, but it also has a little overlap that isn't shown here. So it also does some of those portions, at least in some people. Okay, so plantar surface of the foot and heel. Everybody good? Okay, so we're going to go down tibial, and then we'll go back here for just a second and find, so we had sciatic. We didn't have to learn anything as far as functionality of the sciatic nerve. And then we become tibial, and we stay tibial all the way down. Notice it's behind. It's on the posterior surface of the tibia. And then right around the popliteal region, it gives rise to this nerve that's going to wrap around the front side. This one's called the common fibular nerve. Have you learned yet that if you have a common, it's generally going to split? Okay, so this is my common carotid. It's going to split into my internal and external carotid. This is my common fibular. It's going to split into my superficial and deep fibular. That's just a really, it's really common. It's a really common pattern that you see in anatomy. You're going to see it in the cardiovascular system all the time. So if you have a common, it's going to split. So what I have is this common fibular nerve, but then notice it's going to wrap around, and primarily what it's going to do is anterior stuff. So let's look at what the common fibular nerve is going to do. See it wrapping around the front side, right? And what we have is the medial one is going to be the deep fibular nerve. It's also deeper, but it's more medial, right? And then the lateral one is going to be the superficial fibular nerve. Does that make sense? Okay, so that's pretty easy, guys. If you can look on the anterior surface of the leg, there are only 2 nerves that you need to know, right? And the medial one is the deep fibular, and the lateral one is the superficial fibular. So it gets pretty simple once you know what you're looking for, okay? So let's talk about that common fibular nerve. The common fibular nerve, before it actually branches off, it innervates one thing that you care about. That's the short head of the biceps femoris, and then it's going to go down here, and it's going to split into the superficial and deep fibular nerve. Okay, so the deep fibular nerve, let's do that one first, just right here. So here's the deep fibular nerve. What it's going to do is most of the muscles that are medial on the leg. Yes, medial muscles on the leg. So you can kind of see them. For instance, the tibialis anterior, yeah? The tibialis anterior, and then some other muscles. So it's going to have 3 anterior leg muscles. So since it's got 3 anterior leg muscles, tell me what functionality you think is likely associated with it. Yeah, dorsiflexion. Does that make sense? Dorsiflexion. And if anything, would it be inversion or eversion? Inversion. Yeah, dorsiflexion and inversion. Does that make sense to you? Okay. All right. So 3 anterior leg muscles, and then the sensory function is totally weird. It's just between those 2 toes, right there. So when you get a pedicure and they put those things in there and it tickles like crazy, right? That's where you're feeling it with that thing.
Which one?
Deep fibular nerve. So the only way that that's easy to remember at all is that it goes medial muscles and then it ends up between those 2 toes. Yeah? The medial leg muscles and then end up between those 2 toes. That's odd, isn't it? That one. Okay. So, and then the superficial fibular nerve is here. So here's the superficial fibular nerve, mostly lateral leg muscles. Yeah? So it's going to be responsible for what actions again? Dorsiflexion and potentially eversion. Yeah, got it? Dorsiflexion and eversion. So the muscles that do that, and you can see them here. So how many muscles? Just 2, and you can actually find them already, right? The fibularis longus and the fibularis brevis. That makes sense? Okay, and so what is its functionality? The rest of the functionality as far as sensory functionality is the entire rest of the dorsal surface of the foot. Obviously, they did not divide up the jobs of sensation equally, did they? So the entire rest of the dorsal surface of the foot. Is that okay? Got it? Okay, but look, little bitty cut out right down there for its friend, right? Okay, and then this last one I just added last semester because I think it's pretty damn important. We didn't ever have it there before because it's kind of hard to find on the cadavers, but if it's not important, I don't know any nerve that is. This is called the Pudendal Nerve. And the Pudendal Nerve, do you see it right here? It is coming out of the Sacral Plexus, and then it's aiming towards your junk. Pudendal means shameful. Yes, it is your shameful nerve. And they named it, FYI, when they found it in women. And they named the entire female genitalia is called the pudendum, which is the shameful place. And they didn't go back and rename it the awesome place when they figured out that it was the same one that innervated the genitalia in men. So this is the pudendal nerve. It is relatively hard to find. We only have it dissected out on maybe 1 cadaver per campus, but you know those really big leg models? You can totally see it on the leg models. So just look at the plexus right after it comes out, right? And it's going to be medial to the sciatic nerve, aiming towards your junk, right? So what does this nerve do?
Does it go in the obturator foramen?
What?
Does it go in the obturator foramen?
It goes, no, it comes out of the obturator foramen, yeah? And then it wraps around the bottom, right? Because it's got to aim down here. Does that make sense? So here's what it's going to do, and this will sort of help you understand where it goes, Andrea. It is going to innervate the muscles of the perineum, including like your Kegel muscles, right? And your Kegel muscles, women know what the Kegel muscles are. They help keep your vagina nice and tight. But with men, they actually help you maintain erections. So it's nice for everybody to keep their Kegel muscles going. In addition, if you keep your Kegel muscles tight, you don't become incontinent if you have babies as frequently. I mean, you can still become incontinent. It innervates the muscles of the perineum. It innervates your external sphincters. We appreciate that, right? So you don't poop and pee down your leg. It also innervates your external genitalia, including the penis and the clitoris, which are basically anatomically the same structure. So my argument for adding this to the lab list was that this is the whole reason we have 7.5 billion people on the planet right here, right? And global warming. So it's got some splaining to do, this pudendal nerve right here. Okay, so that's your junk nerve right there. I'm going to rename it the kick-ass nerve when they let me do naming things, right? I'll be like, this is awesome. This is the best nerve ever. Okay, All right, so now we are going to briefly do autonomic nervous system. And autonomic nervous system you do not cover in lab, but you use it extensively in physiology. So why the heck do you not cover it in lab? Well, let me just show you an intro as to why you don't cover it in lab. Because the structures of the autonomic nervous system, for me to dissect them out, most of the structures of the autonomic nervous system, I would need to destroy all of the organs in the ventral body cavity so that you could see the backside of the ventral body cavity, because that's where this is. So I would have to remove all of the ventral musculature, pull out the lungs, the heart, and all of the vessels. So you basically just had to weigh out, how you wanted to use a cadaver. So you might not get to see these. Although Chrissy one of the lab aides did do a dissection so that you can see it on one cadaver. I can't remember which campus it's on. But we don't, It's on Jordan. But we don't ask you it in lab. But it's still kind of cool to see it. So you can go and look at the autonomic nervous system. So you won't see it in lab unless you're just curious and go ask on Jordan campus. But you will see the functionality over and over again in physiology. It's super important functionality. Okay, so we are talking about autonomic nervous system. Let's see how your vocabulary is serving you. If I say autonomic nervous system, is it CNS or PNS? It's PNS, yes. Is it afferent or efferent? It's efferent. And what are the effectors for the autonomic nervous system? Cardiac muscle, smooth muscle, and glands. Does that make sense? So we are going out, innervating cardiac muscle, smooth muscle, and glands, part of the peripheral nervous system. Okay? Now, is it going to be voluntary or involuntary? Involuntary. As a matter of fact, it's not even controlled by the voluntary portions of your brain. It's controlled by older portions of your brain than the cerebral cortex. It's controlled by the medulla oblongata, the pons, and the hypothalamus. Right? You have those in common with a fish, right? So these are really, really old functionality. Does that make sense? So it's involuntary and automatic. And so remember that basically what we said is that you're controlling cardiac muscle, smooth muscle, and glands. And then we had two divisions, right, of the autonomic nervous system. Fight or flight was what? Sympathetic. And feed or breed was parasympathetic. Okay, so we're going to go through those today. We're going to look at the anatomy of each, and then talk a little bit about the functionality of each and how you can kind of predict which one's going to do. Okay, so the first thing is that autonomic, so here's the problem with teaching autonomic nervous system. It's very wordy. So you can do the vocabulary though. And I will tell you, and Amber, who's had phys, and isn't there somebody else in here who's in my phys? That the concepts are not outrageously difficult, but if you don't learn the vocabulary, you can't get the questions right. So if I can't say, for instance, where is the ganglion for the sympathetic division of the autonomic nervous system? So there's so damn many syllables there, but it's a simple question, yes? You have to learn the vocabulary, and it's not particularly comfortable. And then we're going to have preganglionic sympathetic axons and postganglionic parasympathetic axons and all of that crap. So that's really your hurdle with this. It's just the terminology. So first thing I want to tell you about is that autonomic effector organs, see, wordy, have what we call dual innervation. So I want you to imagine the heart, of course, cardiac muscle, because everybody can imagine the heart. Here's what I am saying to you. The heart has two hookups, whereas the biceps brachii has one. The biceps brachii, either you stimulate it or you leave it the hell alone. But the heart has both gas and brakes on it. It has both sympathetic and parasympathetic nervous system hooked up to it. Does that make sense to you? Okay, so autonomic effector organs generally, I mean there are some exceptions, have dual innervation. They are innervated by both the sympathetic and the parasympathetic nervous system. And I'm going to show you some pictures that will look totally overwhelming, but they'll clarify very quickly. Okay, so I want to talk about the anatomic route to get parasympathetic innervation to my heart, like right now when there is no tiger in the room. Yes? And then I want to talk about the anatomic route to get sympathetic stimulation to my heart when the tiger walks in, right? Okay, so here we go. Please note these two pictures that look outrageously complicated are actually ending up at the same place. So look at picture number 1. Ready? And here is picture number 2. They're ending up at the same place. Do you see that? Okay, so here is the anatomic route for the parasympathetic nervous system. The parasympathetic nervous system goes to its effector organs from 4 cranial nerves, yes? And then not a damn thing until you get down to some sacral spinal nerves. Does that make sense to you? Okay, so anatomists who don't care about the physiology, they call the parasympathetic nervous system the craniosacral division. And there's an entire region of hippie alternative medicine, which is craniosacral therapy, which literally doesn't have anything to do with this. Do you see where it's coming from? Okay, but if you were talking about the sympathetic nervous system, so watch me for just a second. Here's the parasympathetic nervous system. If I was trying to chill out your heart, which is what's going on right now, it would come out of cranial nerve number 10, which is the what nerve? Vagus nerve to your heart, right? But then if a tiger walked into the room, that's not the anatomic route. The anatomic route for the sympathetic nervous system comes from the thoracic region of the spinal cord all the way down to the upper lumbar region of the spinal cord. So again, anatomists who don't care about physiology would call the sympathetic nervous system the thoracolumbar division. Okay, I don't care if you know that, but you might run into it in the future. Okay, craniosacral, thoracolumbar. Okay, so let's talk about that and let's figure out what's going to happen. So the sympathetic and the parasympathetic nervous system they both come from and attach to the central nervous system because everything does, right? But they come from different regions. And so I just want to do a couple of practice paths to figure out what's going on right now and then when the tiger walks in. Okay, so right now, everything's cool, I hope, with you. You don't have a quiz, you don't have a test, there's not a tiger in here, right? So what I want to figure out is I want to figure out the anatomic route and then what is happening on my heart, right? But I also want to figure it out for your uterus, right? Okay, so the parasympathetic nervous system is the feeder breed. What do you think it's going to do to your heart? Speed it up or slow it down? Slow it down. But what do you think it's going to do to your uterus? Speed it up or slow it down? Speed it up, because you can afford to spend your finite resources right now on uterine contraction or building up the endometrium or sloughing it off or whatever the hell's going on in your uterus right now, right? So with that in mind, we think about and we predict what's going on with the sympathetic and the parasympathetic nervous system. The way that I do it, instead of memorizing it, is to think about resource allocation, okay? If a tiger walks into the room and you acknowledge that you have finite resources, you have a finite amount of blood supply, you have finite oxygen and finite nutrients, yes? You have to be careful where you're going to send them. And what the sympathetic nervous system will do is only increase the activity of any tissue that could help. Every other activity, every other organ needs to slow the hell down because we don't want to burn up our resources when there's a tiger in the room. Okay, so right now, no tiger. Here's what's going to happen, okay? So what is going on right now is cerebral cortex is identifying no threat, correct? Okay, cerebral cortex doesn't get to decide, but it does get to tell the medulla oblongata, yeah? Medulla oblongata is in control of your heart rate. And the medulla oblongata says, oh, okay, I got you. And what it's going to do is it's going to send out a signal through the cranial nerve number 10, which is the vagus nerve, and you got 2 of them. And they're going to go down to your heart, and they are going to say, chill. Basically, they are putting the brakes on what your heart could do. Yes? Okay? Simultaneously, what is happening is, again, cerebral cortex identifies no tiger, and it says, hey, I know what to do with the uterus, and it sends the signal not out the medulla oblongata, but all the way down the spinal cord. Do you see? And then it sends a signal out to your uterus that says what? You can work now, or you should chill out. You can work now, yeah? Because I can afford for you to work now, right? So the parasympathetic nervous system is increasing the activity of some organs and decreasing the activity of others. But the way to really understand it is to understand what's going to happen when the tiger walks in the room, right? When the tiger walks in the room, there are some things that it is worth spending nutrients, oxygen, and ATP on, and other things that are not worth it. Yes? Okay, so tiger walks in the room, what is going to happen to your heart? Cerebral cortex says, oh shit, tiger. it sends the impulse down to your medulla oblongata that gets to control your heart rate. But the medulla oblongata has to send the impulse down to the thoracic region of the spinal cord, and then it goes out to the heart, which will tell it to do what under that circumstance? Faster heart rate. Okay, but simultaneously, because of finite resources, you need to think about resource allocations. So simultaneously, oh shit, tiger, all the way down the spinal cord to this region, and then you are going to send the signal out to your uterus. This time you're going to tell it to do what? Stop, right? Chill out, right? You don't need any uterine contraction. You don't even care if you have a uterus, right? And in that particular moment, not a single person is going to be thinking about anything related to sex or reproduction, right? When there's a tiger in the room, right? It may be the first time since puberty that you haven't thought about it within a few minutes, but there we go, all the way down. So basically, if you use resource allocation, you will figure it out most of the time. There's a weird little exception that I'll tell you if we get time for. Okay, so with that in mind, those outrageously complicated pictures just simplified, didn't they? I don't even need to tell you. You tell me, what branch of the autonomic nervous system does this represent? Parasympathetic. And this one? Yeah, sympathetic, right? It's super duper easy after you just like get a little introduction. Okay, so basically what these are going to do is they're mostly going to innervate the same organs. And remember that the autonomic nervous system is responsible collectively for the 4 Fs, fight, flight, feed, and breed. And so let's look at the innervation now to an effector and look at the difference between the somatic nervous system and the autonomic nervous system. You ready? Okay, so first thing is, this picture looks super complicated too, but I only want you to look at a specific part of it. I want you to look at the motor innervation of whatever effector you're going to. So this is somatic, which we already did, right? Somatic nervous system, one neuron in the anterior gray horn doesn't form a single synapse until it gets to the effector. So one neuron going the whole way there. But with the autonomic nervous system, again, start in the ventral gray horn, right? Sometimes the lateral if you're doing autonomic nervous system, but still starts right here, okay? And it will go out, look, and form a synapse in a ganglion before it actually gets to the effector. Now, why do you care about this? Which one of these is going to be faster? Somatic or autonomic? Somatic, right? Because you don't have to slow down by doing synaptic transmission, release, diffuse across the synapse, try to start an action potential again, right? This is your emergency response tissue, isn't it? This one's going to be a little slower than that. Does that make sense to you? Okay, so now let's simplify that a little further and say that, okay, generally the pattern is going to go like this. Okay, in the lateral gray horn, or sometimes the anterior gray horn, we're going to have 2 neurons in series on our way to an effector. Does that make sense? Okay, and then there is going to be a ganglion in the middle. This ganglion is different than the dorsal root ganglion, because the dorsal root ganglion's function is what? Sensory or motor? Sensory. This is a motor ganglion, yeah? It's specifically an autonomic motor ganglion. Okay, so with that in mind, you have enough anatomical and physiological knowledge to look at this and tell me which direction the information is flowing, right? It's going that direction. Does that make sense? With that in mind, you can call this one preganglionic and that one postganglionic. Is that okay? Because the ganglion's in the middle? Okay, so the preganglionic and the postganglionic. So this is just a general pattern. And then there's one other thing to add to the pattern. And that is, well, 2 other things to add to the pattern, and that is this. So if we separate that and look at the sympathetic and the parasympathetic, what we will see that is true in both of them is that the preganglionic axon is myelinated and the postganglionic axon is not. Do you see? Same in both of them. But then we see a little bit of difference between the pre and the post, which will affect where you find the ganglion. So stick with me for just a second. We're almost finished with the boring part. Okay, so in the sympathetic nervous system, the preganglionic axon is short and the postganglionic axon is long, which means where are you going to find the ganglia? Close to the nervous system or close to the effector? Close to the nervous system, specifically close to the thoracic region of the spinal cord. Do you see all those little chunks right there? Those are called sympathetic chain ganglia because they're in a chain, or sympathetic trunk ganglia. And again, that's what you were looking at right here. You didn't know it, but look, okay? This is right next to, this is on the posterior wall of the thorax. That's where you would find them. See these little blobs in series that are running sort of lateral to the spinal cord? Those are the sympathetic chain ganglia, and they run down both sides, okay? So those are the sympathetic chain ganglia. And then, so logic question for you now, with that in mind, if the parasympathetic nervous system has long pre and short post, that means that the ganglia are going to be, again, closer to the nervous system or closer to the effector. They're going to be closer to the effector because they've got a long pre and a short post. Okay, so let's look at this picture one last time. You ready? Okay, so please note that it's pretty consistent in this chapter that the pre are brown and the post are this blue-gray color. So watch that for just a second. Ready? Okay, so this is sympathetic nervous system, brown, blue, yeah? These ganglia are actually over here. They just pulled them out so you could see what they were doing. So all of the brown ones are relatively short and then the blue ones are relatively long. Does that make sense? Okay, but now look at the parasympathetic nervous system. The parasympathetic nervous system, look how much brown before you hit blue. Do you see that the ganglion is usually near or on the organ? Yeah, all the way out there. Okay, so one last thing, and then I'll tell you something that confuses the hell out of me about this. I've never figured out how to make sense of it. Okay, so now I want you to think about a spinal cord injury for just a second. Okay, if I had a spinal cord injury, it would be more likely to damage what kind of ganglia, sympathetic or parasympathetic? Sympathetic, because they're close to the spinal cord, right? Okay. If I had an organ injury and injured my urinary bladder, for instance, it would be more likely to damage a sympathetic or parasympathetic ganglion. Parasympathetic. Does that make sense? Okay. So let me just tell you one thing that I don't understand and I've never found a good answer for. Maybe you guys will know. So generally the way that I try to figure out anatomy and try to teach anatomy is that there is a logic that can make it easier to retain, right? I can't find the logic in this one, so I'm just going to go ahead and confess that to you. And people have tried to convince me of their logic, and I don't buy it. So here's the deal. Which one of these should probably act more quickly? Sympathetic. But look, it's got a short preganglionic myelinated axon and then a long unmyelinated one. What? And then this one that like doesn't do any races, right? Has a long myelinated preganglionic axon and then a short postganglionic axon. So just from the anatomy, it looks like this one would be faster. And I seriously don't understand, and I've never been able to figure it out. So if you guys figure it out and you think you can make a good case, I would love to be convinced as to why this is logical, because it doesn't make any sense to me. With the somatic nervous system, the whole damn thing is myelinated all the way down, and so it's super duper fast. So I don't understand this. I just don't get it. And I went to, like the last year, I go to this anatomy and physiology conference every year. It's super fun. We had a big freaking argument about this, a whole bunch of professors trying to convince everybody else why this was true. And I was just like, I don't buy it from any of you people. And then I looked up the literature and I still don't get it. Whatever. Okay. So one last little logic thing, and then we'll start talking about functionality. The last little logic thing is, does it make logical sense to you that if you have dual innervation of, let's say, the heart or any other effector organ, the sympathetic and the parasympathetic nervous system cannot do two different things on the same organ by releasing the same chemical? Yes, they have to release two different chemicals. Does that make sense? Okay, they have to. And so the way that they do two different things on the same organ is that one of them, the sympathetic, releases a neurotransmitter called norepinephrine or noradrenaline, yeah? And the parasympathetic nervous system releases acetylcholine, yeah? And they have receptors for both, and they can respond to them in different ways. Got it? So that's how you can cause two different responses. Okay, so now let's just do a tour. It's not complete by any stretch of the imagination. a tour of sympathetic and parasympathetic functions that are coming from different places to put a little physiology together with the anatomy. Okay, so we know that with the parasympathetic nervous system, you're going to all of these places. And we know that it comes from 4 cranial nerves and then nothing until you get to the sacral region. And this is what? Fight or flight or feed or breed? That's feed or breed. Okay, so let's just look at some functionality that comes from each of these and then some functionality that comes from there. Parasympathetic functionality. Please remember that parasympathetic functionality is when you can afford to do these things that might be extra, right? And you can afford them because there's no tiger in the room. All right, so we have 4 nerves. We have cranial nerve number 3, which is the oculomotor nerve. Cranial nerve number 7, facial nerve, good. Cranial nerve number 9, glossopharyngeal, and cranial nerve number 10, vagus. Never forget the vagus. It never stops being important. It's pretty damn important. You'll see why in just a second. Okay, so FYI, by the time you get ready for your lab practical or for your next lecture test, you need to be able to come up with the name by the number or the number by the name, right? It needs to be stuck together and you need to memorize it even if you have to sing the damn song to yourself, okay? All right, so oculomotor nerve. So you guys learned some somatic function of the oculomotor nerve, right? Which is that it does most 4 of the 6 of your extrinsic eye muscles, yeah? Okay, but there are also some autonomic functions that go with the oculomotor nerve. Is that okay? And so the autonomic functions are controlling primarily the smooth muscle activity of the eye. And what it does is oculomotor nerve is actually responsible for pupil constriction. And if that doesn't make sense to you, wouldn't sympathetic do pupil dilation? Yeah? So the oculomotor does pupil constriction. It's also responsible for focusing. So just the general focusing that you would be doing all the time is a parasympathetic function. It doesn't mean that you turn off focusing with the sympathetic nervous system. It just means that the parasympathetic is always doing it. Okay, so the oculomotor nerve is cranial nerve number 3, and its parasympathetic function is pupil constriction and focusing. Got it? Okay, and then what we have in the rest of the face is primarily glandular secretion, right? Most of your glandular secretion is stuff that you would want to do if there wasn't a tiger in the room. Like keeping your eyeballs wet, making sure you have salivary gland secretion and that you make snot when you need snot, right? So all of that is parasympathetic functionality. So let's see where it comes from. The facial nerve, in addition to doing a bunch of facial muscles, we know that, a bunch of facial muscles, and some sensation in the face, it also causes most of the glandular secretion in the head. It causes tear secretion. I'm not talking about crying. I'm talking about lubricating your eyeballs. Yeah? Lacrimal gland secretion. It also causes nasal secretion. It also causes salivary gland secretion, but not all of your salivary glands, most of your salivary glands. So look at it real quick. Here we go, right here. Okay, so it is going to the lacrimal gland and it's going to most of your salivary glands, but not that big one. That big one is called your parotid salivary gland, and that is done by the glossopharyngeal nerve. So I just did basically all of the juice that comes from my face, right? All of that is happening with pretty much two cranial nerves, right? The facial nerve and the glossopharyngeal nerve. And then the vagus nerve, oh my goodness, this is the busiest nerve in the damn body. Look at this thing. Somebody should give it a vacation. This is cranial nerve number 10. Look at what it is doing. It is innervating autonomic, parasympathetic autonomic function for almost the entire ventral body cavity until you get down to the absolute distal end of the large intestine and then your pelvic cavity and your external genitalia. Everything else is coming from the cranial nerve number 10, which is the vagus nerve. Okay, so it does parasympathetic functionality of all of this. So most of the organs in the thoracic cavity, most of the organs in the abdominopelvic cavity, but not the very last little part. So you guys should be able to figure out what the vagus nerve would do to your heart rate. What should it do to your heart rate? Slow it down. The vagus nerve is parasympathetic. It is not a sympathetic nerve. It's a parasympathetic nerve, so it slows down your heart. Have you guys ever heard of the vasovagal response? Have you ever heard of that? So vasovagal response, probably what killed Elvis. So you can, if you already have a bad heart and you sit in a certain, usually when you're defecating, right? Usually when you're trying to take a poop and you have not been eating a whole lot of fiber, right? And you're compressing like this, you can actually compress your vagus nerve and slow down your heart past where it should be slowed down. You can actually almost stop your heart. If you're an otherwise healthy person, you will get over the vasovagal response, but it can make you lightheaded and pass out. But if you're Elvis and you've been eating peanut butter and mayo and banana sandwiches and you weigh 320 pounds, the vasovagal response may kill you on the toilet, which is the last place that anybody wants to die, right? You just do not want that to happen. Make sure you're wearing your good underwear. Okay, so that's the vagus nerve. So now let's talk about the rest. So the rest of your autonomic effector organs with the parasympathetic nervous system are innervated from way down here at the sacral region of the spinal cord. Yes? Sacral region of the spinal cord. Please note that it does almost all your genitalia, but look here. The testes and the ovaries are actually innervated from the vagus nerve, okay? And it might not make sense unless you realize that the testes and the ovaries are actually the same organ that develop in two different hormonal environments. And when the testes start out up here, right? And then when they actually drop through the inguinal canal, they keep their innervation the way that it was, right? So the testes and the ovaries are still potentially functional if you lost all of this. So think about that for just a second. And then let's talk about what is innervated from down here. What is innervated is the last portion of the colon, the rectum, the urinary bladder, the penis, and the clitoris, which are the same anatomical structure, right? The uterus and the vagina are all innervated from down here. So the activities that come from down there that are the parasympathetic activities include stimulation of defecation, urination, and erection in both sexes. Okay, so let's talk about a spinal cord injury for a second. You ready? Okay, if you have somebody who has a pretty low spinal cord injury, either lower thoracic or maybe even the lumbar region, are any of these functions compromised? These top ones that come from here? No, they're not. You can still have normal parasympathetic innervation of all of that. But what functions are compromised? Urination, defecation, erection are compromised. Okay, so if you know somebody who has a spinal cord injury and became paraplegic, right? So are these things completely lost, or are there workarounds, right? There are some workarounds, right? So how does a person who is a paraplegic know about urination? So they're not getting any sensory input and they're not getting any motor feedback. Sometimes if they don't have a catheter, and sometimes they do have a catheter, then they time their urination, right? So if you can't get the sensory and motor feedback, then you know that you need to go urinate at every X amount of time. And how do you get it out? Well, remember your abdominal muscles can help quite a bit with getting urine out, right? And defecation can happen in the same way. The entire large intestine works, just the last part doesn't work, right? Does that make sense? Okay, so that can be a workaround as well. How about reproduction in a person? So first off, can a woman potentially who is paraplegic, can she become pregnant? Yeah, her ovaries still potentially work, right? But can she give a vaginal delivery? No, she's probably going to have to have a cesarean section. Does that make sense to you? Okay, so males who are paraplegic, can they ever be fertile? Yeah, they can. Erection is problematic, but it's not impossible. There are a bunch of different mechanisms. One of them is a penis pump. And a penis pump is kind of an interesting thing, what they would do in a situation like this. And a lot of times they do, prostate surgery sometimes causes erectile dysfunction. And of course, paraplegia can cause erectile dysfunction, of course, right? So what do? A bunch of different things. Here's one of them that I know about, because the very first cadaver that I ever dissected had a penis pump, and I was so damn confused, I can't even tell you. I'll tell you that story in just a second. So here's what a penis, oh my God, I felt like an idiot. I was like in a room surrounded by anatomists, and I don't know why the hell I started on the groin region, probably because I'm me. And I start dissecting out the groin region, and I'm like counting the tubes, and I'm like vas deferens, testicular artery, testicular vein, testicular nerve. What is this incredibly symmetrical tube? Because here is how a penis pump works. There may be different ones now, but this is the one that I know. So this guy, I found out afterward, had prostate surgery and had erectile dysfunction because of prostate surgery. And so what they did is they actually put a little bladder in your scrotum, and the tube goes up through the inguinal canal and into the penis, paired ones. And so when he wanted to have an erection, just pumped it up. And it goes up, right? But I had no idea. And you don't know, the body donors don't have to tell you that they have a penis pump. They just volunteer whatever information you want. So I just get down there and I'm like, what the hell is happening? And you know that feeling that you get when like your dad asks you to go get a 3/4 inch socket wrench with the blah, blah, blah out of the toolkit, and you're like, what am I doing? And you're like, no, you're going to be humiliated when you come back. This is exactly what was happening. I was counting. I was like, oh my God, I'm going to have to ask this question. Everybody's going to go, duh. But no, they had no idea what the hell it was either, which made me feel better. But it took me like 20 minutes before I asked. So anyway, penis pump goes in, and you can pump it up, and then when you're done having an erection, you just let it out. It goes right back down. And so, of course, the next part of the story was that after I found the penis pump and knew it was a penis pump, everybody walked away. And my friend Christine looked at me, and she goes, you are not going to pump that up, are you?
You should totally.
Yes, I'm going to pump it up. It totally worked. And I get home, and I told my husband, and he goes, see, babe, you can give a dead man a boner. And I was like, we are staying together. Like, that is all there is to it. So, yes, you can still potentially get an erection. How about orgasms? Well, interestingly, orgasms, so the ejaculation part is not the part of the orgasm that people actually love the most. Most of the best part of the orgasm actually happens in your brain. FYI, it's all of these neurotransmitters and hormones that are released. And so even though you might not have the junk activity, you can still potentially get the orgasmic activity that is the part that you seek, right? And it depends on the kind of injury and everything that you have, but it's not out of the realm of possibility. And we have a friend who is paraplegic who will educate you about anything you want to know about about sex. And he's actually taught me some things. Okay, so that is coming from the sacral region of the spinal cord. And so the last little thing for us to talk about before you guys leave is what about sympathetic activity, okay? So those are all parasympathetic activities. And so with sympathetic activities, it's all coming from T1 through L2, yeah? Okay, so spinal cord injuries, do you see? If we have a high spinal cord injury up here, I don't know, C7 even, most of your parasympathetic activity is going to be okay, but your sympathetic activity is going to be compromised. And one of the things that's kind of interesting about this is that, so let's say I have an injury right here, C7, between C7 and T1. Tiger walks into the room. This person, what is going to happen to their heart? Well, their heart rate will actually go up, but not until you actually dump it into the bloodstream and it gets delivered to the heart as adrenaline. So you'll have a seconds to minutes lag before you actually get this response. Does that make sense? It's kind of interesting. So it doesn't get there as a neurotransmitter, but it gets there as a hormone eventually. Okay, so examples of sympathetic activities on target organs, these are all motor. And again, we're thinking about resource allocations. So it will turn up some tissues that could help. It will turn down everything else, yes? So tiger in the room stimulates cardiac muscle, yes, which of course increases your heart rate. Causes vasoconstriction of most of your vessels because of resource allocation. So where are you going to want to send the vast majority of your blood?
To your heart.
Heart, brain, lungs, skeletal muscles. Everything else can suck it. right? And the net effect is it raises your blood pressure because you're doing more vasoconstriction than vasodilation. Causes dilation of the bronchioles. Does that make sense to you? Yeah, more air in. Inhibits digestive organs and glands, turn those things off. Inhibits reproductive organs. Eventually it will heat you up, so your sweat glands will activate. It doesn't happen instantaneously, but it heats up your body, so your sweat glands will activate. And it also will stimulate the adrenal medulla right here, the adrenal medulla in the adrenal gland, to dump adrenaline or epinephrine into your bloodstream, right? And even if you had a spinal cord injury, it's still going to get there through your bloodstream. It'll just be a little slower to cause the response. That make sense? Okay, last reminder is that you will have a quiz over spring break. I will post it within the next 2 days. It will definitely be due before you come to class. I will put the specific due date on there when I put it up. Okay?